treated COVID patients, so you can share your experience if something different, or you feel that something to add in this what I have what I'm sharing. So in COVID wave 1 and COVID wave 2, they have made me the chairperson of National Cancer Institute Jajjar, because it was a budding cancer institute and only few patients were there, and there were almost 700 beds with all the beds with oxygen point. So when COVID wave 1 came, that time also that was the most potential and best suited place for COVID patients. And when COVID wave 2 came, this was the best place. So we stopped immediately all the cancer services, because every patient need to have a on oxygen point, and National Cancer Institute became the COVID center again. And now again we have almost stopped COVID, but and started cancer, but I don't know how many days this will go on. So this was the situation. Now I will share basically not only a whole of India, because whole of India, I don't think that it's the right time. Right, I am the right person to talk, but I will give you the status of India in 1 or 2 slides, and then I will speak about National Cancer Institute. So we all know India's population. It's a thickly populated country, 1.38 billion. In first wave, on 17th of September 2020, there were cases were 97,894 cases per day, with 1,290 deaths per day. But in wave 2, on 6th of May 2021, the number of cases, the maximum number of cases were 4,12,618 with 3,982 deaths. The bigger challenges were that doctor-patient ratio all over the country, 1.34 doctors for almost 1,000 citizens. This is the this is the biggest challenge for all of us. In other diseases also, but it became very obvious in COVID. When we talk about GDP, it is only 1.6%, and 1.6% only goes to medical expenditure. And this we have witnessed the worst crisis of healthcare crisis I have ever witnessed in the country, or anybody has witnessed in the country, because of this, that we are not spending a lot of money in a medical side. The next big challenge is 29.1 million people are, we say that, fully vaccinated. So although 29.1 million people are fully vaccinated, but this covers only 2.1% of entire population. Because of thickly populated country, even if number is very high in comparison with other countries, but it is covering only 2.1% of entire population. And when we compare the wave 1, first wave and second wave, this is just in a cumulative number. We can see that total positive cases in till now is 30,228,709. Out of this, in first wave, although number were less. In second wave, although period was only 2 months, but the number you can see that it was too high. Similarly, death also we can see that although number of cases died in wave 1 were less in spite of the high number, and the percentage ultimately, if we see the percentage death rate is ultimately cumulative death rate was 1.34, and when we compare in comparison with number, I think it remains again 1.3, 1.4 and 1.3. This is India's status. And this was just a figure which I have taken from the Google, that this is the way on 22nd of June, number of cases were very less, and 18th in wave 1 and wave 2. But suddenly in 13th of March, we can see that sudden rise were there in April and May, and then suddenly it has gone down. So this was the number in terms of number, the whole country's status. When I talk about National Cancer Institute, this is wave 2. I have not brought the figure of wave 1. The total number of patients in within 2 months, from 9th April to 17th June, I have brought this figure. Uh, only we have seen 2,086 patients, and this is the number of patients, the day-wise numbers. So you can see that any of given point of time, almost for 15 to 20 days or for a month, we have admitted almost 100, sometime 95, 80, and 50, 62. So imagine if in a single institute, if 100 patients, COVID positive patients are coming, and in a very sick condition, how this would have been, and how we must have. This was a real crisis, which I will explain further in my further slides. This was the time to hospitalization after symptom onset. When we analyze that, when these patients have visited hospital, so what we have found that 54% of the patient, they although visited first in the first week, but almost out of 2,556 patients, they visited second week. This means for almost 2 weeks, everybody tried that they should be all right at home, and they tried all sorts of medication, like they were doing self medication, or they were talking to the nearby doctor, or I don't know what. Everybody was taking ivermectin, steroids, and all these self medication. They did almost for 2 weeks, and they came after 2 weeks, when the saturation was falling, they came to the hospital. So maximum number of patients, they visited hospital in the second week after doing self medication, and lot of self medication. So when we do the total outcome, if we outcome update to the total number of outcome. So currently in the COVID center at NCI, we have although converted again oncology center, but 2 of our floors are still occupied with COVID patients. Out of this, 17 patients are still in ICU, and those ICU patients, those are still from the right from the in the month of April they have come, and out of 17 patients, 7 patients are on ventilators, and they are still struggling to survive. Or so 17 patients are on in ICU, and rest of the patients we are still struggling because they are COVID negative. They have become COVID negative, but there is no place to keep them, and they are on high flow nasal cannula or on high flow oxygen. So total number of patients are 73. We have discharged successfully 1,573 patients, 1,573 patients. But this is a very important figure, that out of 2,000 patients, 405 patients, it is almost, the death rate was 19.4%. And these are the number of patients we have transferred. 25 patients. Sometimes patient wanted to go to the private hospital, or they wanted to go to another center, or sometimes if patient requires some neurosurgery immediately, then we transfer to the main hospital. 10% they left hospital against medical advice. So this was the total outcome analysis. Now, if we consider outcome by age group, and what you can see that we this time we have found that maximum number of patients were in group of 18 to 60 years of age. In last time, the maximum number of patients were in the group of more than 60 years, but this time most of the patients were relatively young patients. And what we can see that when we analyze the death versus age, what we have found that 37 almost means that death were maximum in the group of more than 60 years, and in the age group of less than 18 years, only 4 patients died, and all these 4 patients were oncology patients, advanced stage malignancy patients. So all these children were 5, 6, or 10 and 12 years old, and they were malignancy patients. So the maximum number of deaths were on more than 60 years of age. When we did the comorbidity analysis, means like many patients were having a lot of comorbidity. So I will I think this, rather than discussing this slide, we can discuss this better slides which gives a good analysis that out of 405 patients who died, most of the patients were having some or the other comorbidity, like hypertension and diabetes, or CKD, or hypothyroid and everything. But see that almost Maximum number of patients were having some kind of a comorbidity. Almost 1,500 patients were having comorbidity, but the death happened in 405 patients. So this means that it was not the only comorbidity which was the reason of mortality. This is the severity status which we could analyze only on 390 patients. What was the severity when they were presented? So what you can see that out of 390, 305 patients presented in severe degree of COVID, with severe grading. And out of these patients, when they presented the SpO2 level for those on oxygen. So patient came with oxygen cylinder, but SpO2 level, in spite of with oxygen, SpO2 level in less than 80% was there in 48 patients, and 80 to 93% was in 63 patients, and more than 93 was in 48 patients. So this means that these patients are very sick. 5 patients came broad dead, and 20 patients died on the day of admission because they were quite sick. So less than 80% of patients, those came with oxygen, means they were quite sick. And 166 were brought on room air with hypoxia less than 83. This means in 166% patient, they could not arrange oxygen. We all remember, Indians all remember that there was a time when there was no oxygen cylinder available in whole of the country. So 166 patients out of 2000 patients came without oxygen because they could not arrange oxygen, and they came in hypoxia with saturation less than 90 and 93. When we analyzed with the vaccination status, so we keep saying that you get vaccinated and you will be all right and you will not get COVID and you will survive. So see the status of vaccination. So we all remember that vaccination is started mainly in more than 60 years of age. Everybody said that if you are more than 60 years of age, or if you have comorbidity, you can be vaccinated. So the out of more than 60 years of age patients were 401. Out of 401, only 22 patients were completely vaccinated, and out of completely vaccinated, 7 patients died. Similarly, 123 patients received only 1 dose of vaccination and 35 died. And no vaccination is 256 patients, and out of 256 patients, 114 died. So this shows that vaccination has some correlation, that it has really prevented mortality. When we come to the 18 to 45 years of age, so 18 to by the time this was there, that 45 years of age people can also get vaccinated, and most of them were healthcare workers. So what we have found, that 18 to 45 years of age, completely vaccinated people were 34, and there was no mortality. Only 1 dose received by 78, and there were only 5 people died out of 78. But when they have not received vaccination, 648, 65 people died. So this means there is a correlation of vaccination. If we will vaccinate our whole of country, definitely mortality will be less. This is the outcome at by level of care. Means ICU, 3 levels of care we have provided: intensive care, high dependency unit, and ward care. Means ward. So in intensive care, we have admitted 167 patients. Out of 167 patients, almost 80 patients, they died. So this means almost no, I think this percentage is less. So maximum people, those let me see this here. Okay, so percentage is wrong. So maybe 80 people died out of intensive 167 patients. In HDU, 319 patients we have admitted and 96 died. And in the ward, 1,170 patient admitted, and in the ward only 169 died. So this also give an idea that level of care is directly proportionate. Means like when people were sick, they died. So in the ward patient, the death were It's like it is not very low. 12.6% is also very high. But most of the patients, those who died in the ward, were the time when we were struggling that how to keep the bed for them in HDU and ICU. Our HDU was full. SDU was of 60 bedded and ICU was of 50 bedded. So almost 110 beds were full, and we were unable to shift those patients in the ward, those who were sick. So we have created the level of care to SDU. We tried to create for these patients also in the ward, but still we couldn't we couldn't. We were still 169 patients died in the ward. This is the baseline profile, investigation profile of disease, the mortal patient, those who died. So we could analyze in 345, and you see that it is not that the level of ferritin, D-dimer, C-reactive protein, and when we see that baseline investigation profile, when we see, this does not give any impression that there is a direct correlation. But when we compare that patient, those whom we discharged, and patient who died, so exact number we could analyze were 874 patients, those we discharged, and the patient who died were 298 patients. When we analyze these patients and when we compare, we can see that the laboratory parameters of these patients, there is a huge difference. The people, those who died, their TLC counts were high at the time of admission. The ferritin level was quite high at the time of admission. D-dimer was quite high at the time of admission, and C-reactive protein was also very high. So this means these patients came quite sick. That's why we couldn't make it. They couldn't make it. When we compare directly at NCI Jhajjar, the first wave versus second wave, there is a huge difference, and this gives quite a it is eye opener that we saw 6,372 patients in first wave versus 2,002 patients in till May 20th. This figure is still only till 20th May. The mortality out of 6,372 patients mortality was only 2.4%, 152. But out of 2,000 patients, 345 patients died straight away. Mean age, when we compare, I don't think there is any difference. It is 58 and this is 47. Mean duration of hospital stay was also almost similar. There was 11 days in first wave and 7.2 days in second wave. Male versus female ratio, there is a difference. In first wave, we used to always say that females are not the one who get affected with COVID, but this wave said that almost equal number of females were also affected. What can be the cause of increased mortality, which we tried to analyze, and this is just a general, this is not scientific and based on evidence. We are assessing that what are the mortality indicators and predictors of what was the indicators of mortality. But what I have enumerated, that we have admitted all the patients those came to NCI because there was no filter criteria. Even if a patient is coming with 30% saturation, we were admitting. Late presentation can be the cause, almost in the second week almost maximum patients presented. Already all COVID medication, people were taking ivermectin, steroids, and any sorts of antibiotics. So already they were self-medication can be the cause. Morbidity is an important cause. Vaccination is maximum people were not vaccinated. This time nature of the disease was very aggressive. We didn't get time for preparation, and this is true that within 7 days we have prepared everything. Our oncology work was going on peak. All our 8 OTs were working, and within no time we have been asked to start because the whole AIIMS, the main center of AIIMS COVID center, was full of patients. So we have prepared ourselves within a week. So there was no time for preparation, and for 15 to 20 days it was like a flood of patients non-stop, 190 or 85 patients per day. So most important cause of death which we have found is severe ARDS with respiratory failure and ARDS with refractory hypoxemia and shock. Now came the era of mucormycosis. So we all know that suddenly a time came that the whole country was struggling, that there was a lot of patients with black fungus. So at NCI Jhajjar also we have admitted 63 patients of mucormycosis. Out of 63 patients, 48 patients are diabetic. And we keep saying that people, those who have taken irrational steroids, they are getting mucormycosis, but only 28 patients out of 60 patients, 63, they have received any sorts of steroid any time of the disease. We have operated almost, I think this figure is again wrong. Today's figure is 53 patients we have already operated. And these are the things which we have done. And surprisingly, in mucormycosis, we didn't still now we don't have any mortality. So few important and effective contribution which I want to highlight here, that within a week we have created one very important screening area because 100 patients were coming. So what we have created is very good screening area for which we have almost finished the manuscript. Here in screening area, we used to screen the patient. We used to give steroids and we used to give any deltaperin or low molecular weight heparin over there only if patient is coming with low saturation and falling into the criteria of severe category. We used to send baseline investigation over here only. So, and we used to write down treatment at screening area so that by the time patient will go to the ward, and here we used to decide that this patient should go to SDU, ICU or in the ward based on the severity, so that by the time patient will reach to the ICU, SDU or in the ward, doctors, because there were only two doctors, imagine, for almost sometimes 50 patients, sometimes 60 patients. So it was it for 2 weeks we couldn't do anything, and all the patients we were sending to the wards. And this has happened, truly this has happened, that by the time doctors used to finish their rounds and used to reach to the last patient, already patient died. So this has happened, and that's why we have created a very good screening area where we used to start treatment, and then we used to send a message to the, because again there was a chaos, because as soon as patients relatives, they will leave the patient in the COVID hospital, they start calling that what has happened to my patient, where is my patient, how is the condition, so whether this treatment has started. So what we have done, we have started sending messages at right after the admission, that your patient we have admitted and he is in ICU or SDU or in the ward, bed number so and so, ward number so and so, and communication team will call you during this time, and you can call this number during this time. So the communication was absolutely clear, and everything was well organized. After 2 weeks, change attitude of nursing staff. Initially nurses were very reluctant to miss, like they were quite reluctant, not because they are not in a habit of working, but they were so scared of seeing the patient, so many patients, and everybody was asking, give this injection, give that injection. So but after some time nurses attitude has also changed, because how we have changed the nursing attitude, because if a nurse will skip the steroid injection, for example, and patient will become either moderate to severe, then we used to give incident wise, we used to catch, and we used to ask this particular nurse, see, this has happened probably because we have missed this dose. So with this thing, I think nurses, they have changed, and they started taking it everything very seriously. And initially they used to don only for 4 hours, although the duties is for 6 hours. And doctors, in the comparison, they have duties of 6 hours and they were donning for 8 hours. So when they have seen this, that what they are not doing correct, they started donning for whole 6 hours, and automatically all everything got streamlined, and their attitude has changed, and probably the care has improved. Similarly, interns, we have posted our interns in the wards, and was the responsibility of interns was to go to every interns used to get 20 patients, and their responsibility was just to go to the patient, talk to the patient, ask if patient wants to talk to the family members, just give the assurance that we are doing our best, Based on the status of the patient, they used to give the right honest information to the relatives. And if the patient is very sick, they used to inform the duty doctors that this patient should be shifted to HDU or ICU. So interns contribution, interns means like although internship we hardly get any job, hardly get any work to do, but in this COVID, interns contribution was a huge, and it was a great contribution. Uh, this also has really made a lot of difference that laboratory, radiology, and microbiology, they were working round the clock. So initially for 15 days, there was a because they were not expecting that this was huge surge will come. So they were working around when they started working round the clock. The whole the care improved and quality improved. Streamlining of communication strategy, when we started streamlining, the interns were also communicating. When in the screening area, we were giving the information that this is the place where you will get the information. This really made a huge difference. Once the relatives are well communicated, I think our stress is become less. Otherwise, there were chances, there were incidents that one patient is inside, and at least 15 people used to call for how is this patient. If the patient is influential, or is a doctor, or is an MP or an IAS officer, the whole country used to ask that what is happening to my patient. So it was really a nightmare that so many phone calls. When I used to reply to one person, the same time when I used to finish my reply, there used to be 5 calls. So streamlining of communication strategy was very important, and we did that. Helping hands for all corners of AIIMS. It's like it is every department they have contributed, and they have asked me that whether you need more residents or more faculty. Everybody. Data capturing we have started from our preventive oncology team. They have started right from the beginning. There used to be a regular teaching program that what is basically expected by an intern in the COVID area, what is expected by a house surgeon, non-academic JR or academic JR. So all the teaching program, what is treatment for mild, moderate, all the protocol and policies were in place. And this used to be, every day there used to be a class from 8 to 9. People were free to join, whosoever is free. And we have made sure that everybody has attended that class. Plus, infection control practice should be there. And plus one more thing which we have taught, and I'm very happy to say that even an anatomy resident, they have learned how to give oxygenation to a patient by different sources, by venturi mask, by high flow nasal cannula, or by patient, if patient is on ventilator, how to handle ventilator. So even anatomy, physiology, biochemistry, all residents were working. So almost 35 departments residents were working, plus 25 departments of faculty were working together in this area. And everybody was, we used to make sure that they are well versed in infection control practices, and also in the protocol and policies, in the creating dedicated area of children for, my god, we have created a dedicated area for children, 24 hours availability of hospital administrator staff, duty officer. They were also very, very important people, and they have really worked hard. 24 hours, if there is any problem, we used to contact hospital administration. Extraordinary sincerity by security, sanitary worker, and cafeteria people, because still I remember that many people after leaving, they have said that the best food we have received is in National Cancer Institute Jhajjar in AIIMS. So they have never missed the very, I used to work hard with the cafeteria person also, that there should 24 hours they should get something to eat. Even if they are coming in the midnight, they used to get Maggi, omelette, or bread butter toast, or tea, coffee all the time. Mucor team is a dedicated mucor team. They are also working hard. So these are the few important points and effective contribution from various departments, which has made a huge difference at National Cancer Institute. What are the areas of improvement which I have given to the administration that we need to immediately change the hospital. This is, I think everybody must be suffering, must be affected. That if any of the if you want to shift your patient to, for example, if a patient is for more than a 1 month, and you want to shift to the pulmonary medicine department because he is still requiring high flow oxygen, they want negative reports. But we all know that this patient is now by the time negative. But so there is still there is no policy right now, and we are they are requiring negative reports. So there is no policy about this. We need to have a dedicated space to rehabilitate post-COVID patient. Now there will be a problem of all post-COVID patients, because now huge surge of patients coming. Still, they are requiring oxygen. They are getting fever again, and many a times we are again starting steroids. So there we need to have a huge space for post-COVID rehabilitation. Systematic approach to evaluate and treat patients who are requiring long-term oxygen. We are sending patients with 1 liter, 2 liters, 3 liters oxygen at home. But what will they do? Sometimes they really call a lot of time and they ask that when we will get rid of oxygen. So what should be the approach? We have to think of this. Judicious allocation of resources and manpower based on the needs. Many a time we have found that resources and manpower was not allocated in a judicious manner. We need to better prepare for next health. Now, if at all we are thinking that third wave can come, we have to be better prepared, because I can tell you that for 15 days it was a nightmare because the huge surge of patients was coming. We were not prepared, but after 15 days till now, I can say everything was streamlined. But it really took a lot of energy, I think a lot of time, and it was a lot of thinking. But if we would have been better prepared, I still feel that we could have reduced mortality and morbidity. And there is a huge need to integrate palliative care or end of life care in emergency, especially emergency area. So what can be our opportunity? I think simple treatment guidelines. It is the treatment of COVID is very simple. Practical patient management. I think there is hardly any. It's not a very rocket science that if you want to give oxygenation to the patient, it's very simple. Improved patient communication can be a better opportunity. Improved dissemination of public knowledge. Get every Indian vaccinated. We are seeing great community participation in these days. A lot of NGOs are coming forward and giving help to the patient, those who are grieved patient, those who are still suffering. Necessary infrastructure to help patient created in few days. Within few days, there were a lot of oxygen plant came and PPE, and there was hardly any problem. And at least in AIIMS, there was no shortage of PPE and medicine. What are the learnings? I can say that we have to improve our vaccination program. Even if we say that millions of people we have vaccinated, but still we have not vaccinated more than 5 to 10% of people. So we have to improve our vaccination program by increasing supply and distribution. We have to improve poor infrastructure. This I am telling everything about All India Institute of Medical Sciences. But what must have happened in the village, in the periphery, in the district hospital, we don't know. Where the whole hospital is run by single oxygen cylinder. I'm not sure that how they must have managed and how many patients they must have died. Reduce further SARS-CoV-2 transmission while the vaccine is rolled out. We have to give accurate public updates to public at regular intervals, which we are not getting at all. We have to forecast and track emerging and more transmissible variant by improving genome sequencing, which is there are a lot of laboratory, but hardly output of these laboratory is hardly anything. There are other learnings are that continuous education of public to increase the necessity of masking and social distancing. If you will go to Delhi in the basically Old Delhi or Sarojini Nagar market or maybe Lajpat Nagar market today, right now, you will see that 90% of people, they are not using masks, and there are hardly any social distancing. So we have to do this immediately. Completely stop religious and political mass gathering. You must have seen that before COVID wave 2, we had Kumbh Mela also, and we have political, even our Amit Shah has done so many political gatherings, and you have seen the result of those political gatherings. Lakhs of patients died, and thousands of patients died in a day. We have to teach volunteer quarantine and regular testing. The people, those who are not required outside home, they should do volunteer quarantine and they should do regular testing if they have any symptoms. We have to take care of exhausted healthcare workers, those we have not given any importance. This is most important. And for this, what I have done immediately after the when COVID wave 2 is getting means like number of patients were getting reduced, I have given compulsory off to all my residents and all my faculties, those who were working since beginning of April, 9th April, they were working. Immediately, I have started giving off in a scattered manner. 1 week of everybody is getting. So this is also very, very important. And I have not given off to my residents and my faculty member because I have seen that many of them are getting infected and they are getting infected and they are getting
I think they're connectivity problems. Dr. Shushma, are you still there? Tanan, is Dr. Shushma still online?
She appears to still be connected to Zoom, but I think she has disconnected.
Yeah. Can we let her know?
Oh, okay. It looks like she has been disconnected.
Hello, Dr. Nusrat. Nice to see you.
How are you, ma'am? How are you doing?
Okay, thank you. Yes, so glad to see everybody. Dr. Sweetie is there too.
Same here, ma'am. So good to see you.
What is happening to Dr. Shushma's connection? Dr. Maksoda from BSW. Yeah.
Sorry, my internet got disconnected. Should I finish or we are started discussing?
No, we haven't. We're waiting for you to come back. I think we must
teach and control our media. I'm just finishing. These are few last slides.
Please,
and
yes.
we have to prepare ourselves for post-COVID challenges that are ahead. That post-COVID syndrome patients, post-COVID syndrome amongst healthcare workers and patients, prolonged grief of lost loved one. We know the families. Many of the families, there are only single members remaining. Rest all people died within a span of 1 month. Social and mental stigma among survivors, revival and reinforcement of healthcare infrastructure, increased mortality of patients suffering with non-communicable diseases. This is a bigger challenge because I can witness that many of our cancer patients, those who were posted in those 2 months, now they have become inoperable. So we have to look after these patients also. Rehabilitate of patients with crippling post-COVID fibrosis. I have seen patients, they are coming in pulmonary medicine department they are crippled. We have discharged them, but they cannot breathe properly. And how not to forget this pandemic and learn from it in future. That in future, we should remain better prepared, and this is most important challenges. And I think that palliative care, as a palliative care physician, we can answer all these post-COVID challenges very well. and we can be a big asset for whole of the country. And this I have given to Ministry of Health and Family Welfare, and I have given a proposal that palliative care physician can really help in post-COVID challenge to handle post-COVID challenges. And in AIIMS, we have created a multidisciplinary department, and where palliative care physician has a major role. This was the team. There are like a lot of teams have worked. I think I will not go into the detail because I want to hear from others. These were the various teams who were working over. This
Dr.
was
Sushma, would you want to share your slides?
because oh you okay, you can't see the slides.
No, we cannot see it.
Sorry. My God. So where is the shared screen? Is not coming. Just a minute. Oh God. Now can you see?
Okay, now we can see it.
Okay, I will do the slideshow. Just a minute. Slideshow. Oh, anyway, so this was the regular meetings. That's why I couldn't attend our classes. I missed so many CTC classes because I was attending and doing these meetings regularly. This is a very important feature which I told you, the changing attitude of nurses. So what nurses did when I used to take a lot of briefing from nurses, and I used to really counsel them. So what they have done, whenever they used to get off, they used to come volunteer to take care of the patient, those who are in ICU. So volunteer group they have created themselves for the patients, those who are in ICU and HDU, because we were unable to provide 1:2 or 1:5 ratio also. So there used to be 4 nurses for some time for 20 patients. It is just not possible to take care of 20 patients by 4 nurses. So this volunteer group of nurses been created, and this volunteer group has become a famous group for whole in a whole of the Delhi. So these nurses in their offs, they used to come to ICU and HDU, and they used to take care of the patient. So these are the few papers which we have published in out of COVID. This is the concern of healthcare professional managing COVID patients. So what were the main concerns? The risk of infection to self and family, disruption of daily activities. What were their coping strategy? Reassurance and appreciation of seniors. If a senior will appreciate, they used to work hard, even for junior JRs, especially JRs and SRs. Connectedness with the family and friends. Feeling of pride. Sometimes they used to feel pride that they are doing very noble work. A team approach, really making a team makes a lot of difference. They used to, almost all residents, they have sent a message that we have learned how to work in a team, and proper duty hours and breaks really makes a whole huge difference. Second paper which we have published, that what were the concern and coping strategies of people, those who were in quarantine. So the physical problem which we all know, that they were having fever, cough, sore throat, but emotional problem, they were worried, they were anxious, and they were sad. The coping strategies of all these patients were, they almost 80% patient they participants got support from family and friends. 57 maintained their daily routine in spite of that they were in quarantine. 70% selected praying, and 40% of patients they used music as a coping strategy, and almost 2% of patients they were unable to cope. And this is another very good paper which is now going to be published in Indian Journal of Psychiatry. A questionnaire-based survey which we have done for stigma, and what we have found that 66% of patients they were hesitant to inform their family and friends if they are getting some signs or symptoms and COVID. 58% of patients they felt ashamed, guilt, and worthless after getting COVID. 52% of patients they felt discriminated even after they have recovered. Means they have recovered, and when they go for job, they feel that people are discriminating them. 71% felt that discriminated by neighbors. If even the neighbors they are discriminating them, and they are blaming themselves that because of me my grandmother got infected. 48% felt less respected at workplace and excluded from the peer group. 35% felt promotions and perks will be affected. And It's a big number. 2.4% people, they were fired from their work because they got COVID. So sudden surge have stressed our healthcare infrastructure and our residents, but they could not deter our commitment, and we really worked hard for since 9th of May, and we are still working hard. And this was my experience, and I am happy to listen from everyone that what they have experienced during treating their COVID patients. Thank you very much, and I will stop sharing so that we can see everyone. So how to stop sharing? Yeah, stop sharing. Okay. Thank you very much for giving this opportunity to share my experience. Seema. So we can start from Naveen. Naveen, what is your experience?
Madam, I was not directly involved in the COVID care, but we used to get referrals from ICUs. So we have worked very closely with the ICUs. So in the first wave, we have seen around 50 patients referred to palliative care. No, yeah, close to, yeah, 50. And in the second wave, I think we haven't audited our data, but it's definitely more than 100 or 150 cases. It's quite a huge number. And we also operated in high dependency unit within the COVID section. So some of those patients who are, we had a COVID checklist or a criteria in which we had some form of a triage system where patients who are probably not going to get benefited or are having a severe form of COVID, unlikely to recover, they were triaged to receive palliative care, and we managed some of these patients. But we did a lot of counseling. We have done symptom management, end of life care for a significant number of COVID. Probably the difference is you were in the thick of it and you managed all the COVID patients very actively. We probably played a very supportive role to the ICUs in managing COVID. So that's how was our role here.
Absolutely true. When a palliative care physician is managing the whole COVID, there was a huge difference. Because even it's like all our onco and palliative medicine residents, we could see that they are giving triaging, they are taking end of life care, they are managing, they are counseling relatives on phone. I think this makes a huge difference. If you are a palliative care physician, you better manage these type of crises. This is absolutely true. Thank you.
Thank
so
you. Thank you,
Shamim, Afroza, do you want to share anything from Bangladesh side?
Ma'am, thank you, madam. I want to ask a question, ma'am.
Yes, please tell me.
Do you use morphine in case of respiratory distress in COVID patients?
Yes, we have given to 15 patients low dose of morphine. When patient used to be very breathless on high flow nasal cannula or non-rebreathing mask, we have tried morphine. I am not sure that whether we were successful, but out of 15 patients, we have 5 patients ultimately we have intubated. So I think we have not done it properly, but we used to use morphine for these patients.
Thank you, madam, and thank you for the nice presentation. It's very quite similar the experience you shared in India, and here also in BSMMU, also in other sides of the country, also the very similar situation. People are very reluctant to use the mask, even nowadays also, and the gathering and the political situation. Even in the slum area, we know we have 2 centers in the slum area. So people thought that the doctors maybe do something wrong. So we use the mask and we got the COVID, and they will not infected by the COVID. So there are some myths like this, but situation is sometimes now changing. And nowadays our local area, the lockdown for the increasing COVID, mainly in Bangladesh and India, the border area. So, but situation is getting worse nowadays, getting worse. So, there's some coming Eid also. Maybe the situational government will do some strict rule for the upcoming days. But we are trying to coping for the hard days. Thank you, madam.
Thank you, Shami. Kunal, you want to share your experience, Kunal? Kunal?
Yes, ma'am. Good evening.
Good
Thank
evening.
you for sharing, and this just shows the importance of data collection and making a cumulative thing. So I was not directly involved in COVID care like Dr. Anupama said, but a lot of our patients were getting COVID positive, and we were kind of indirectly managing a majority of them in home isolation. In fact, myself and all of our family got affected by COVID, and it was the same time when the peak. I was positive on 6th of May. The date that you mentioned was at the highest number, and I had to be hospitalized also for 5 days. So I had the other side of the party, I would say, and it is quite a tense atmosphere when everyone in the family is affected. People are in different rooms initially when some are positive, some are not. So it is not an easy situation, and I can relate from that point of view when you become the patient yourself. And only other thing I would add is there are a lot of people in terms of panic who have purchased a lot of things like oximeters are one, and the other thing is oxygen concentrators. And that is where we are trying to get some rational use subsequently. Our organization has now got 3 such oxygen concentrators, which we are trying to put into use for palliative care subsequently, because majority of them are not going to be used continuously for a long time for COVID. And it is just a panic reaction, and people are just buying those things.
This is absolutely true, Kunal. There was a time when out of 14 of my faculty, 7 were COVID positive. And out of 7, 3 were getting remdesivir. This is my own faculty in my department. I was shocked and I was so scared because of my faculty members. And it was a nightmare that when they were saturation was falling and they were getting remdesivir and they were on oxygen. Dr. Vivek was there with you. Dr. Vivek, what is your experience in the same hospital?
Ma'am, good evening. Wonderful presentation, ma'am. Actually, you have covered almost everything what we have done or we have come across. Am I audible, ma'am?
Yes, you are audible. You are audible.
Yeah. So if I compare this wave, as you said rightly, the younger population was involved. I got almost all, because I was looking after the post-COVID ICU patients. So they were coming to us once they are negative after 14 days or 15 days, and they were on the HFNC, NIV, NRBM, or some patients were on the ventilator. But the several changes this time we saw that even the patient for first 10 days or 12 days were maintaining with the high oxygen flows, and then after 14 days they started deteriorating and they went on ventilator and they had a pretty poor outcome. A lot of pneumothorax, pneumomediastinum, ma'am, we have seen. I don't think we have ever seen in our career this much of pneumothorax. And moreover, we learned how to save oxygen this time, because looking at the Delhi situation, we really worked very hard in Punjab to save oxygen, ma'am. Exactly. And as you rightly said, D-dimer interleukin 6 level, in fact, 15,000 or 12,000 even D-dimer we have seen in a few patients, and they had really a bad outcome. Besides,
yes, yeah. Go ahead, please.
And besides infection, bacterial infection and fungal infection, we have seen a reactivation of tuberculosis in these patients, ma'am. Few of our patients, they had the reactivation of tuberculosis. So these are the few points. It's still like we did ECMO in almost 16 patients throughout the course. In the second wave, one ECMO went for 70 days, but unfortunately his lung did not recover. Another guy after 25 days has recovered the lung, and third we have shifted for the lung transplant, because again he was not recovering. So it's a really bad experience this time, younger population and non-recovery of the lung.
You are absolutely right, Dr. Vivek. I forgot to put this slide that almost 25% of our patients, they got pneumothorax. And it was because of high PEEP which we used to give to these patients, that somewhere we wanted to maintain their saturation, and when we give high PEEP, and probably their mucosa is not healthy, and people got pneumothorax. It was
But-
again a bad complication.
Yeah, possibly there are formation of pneumatocoel as well, which is
Probably.
rupturing, and they have the subcutaneous emphysema and bronchopleural fistula as well. Thank you,
Hanife,
ma'am.
what you did for 2 months in these days, Sister Hanife?
Hello.
Hello. What were you doing in these days?
Well, we are in Mumbai right now,
Okay.
and we are doing a training in 3 pediatric hospitals, and we are
okay.
teaching pediatric MNIC, and during those 2 months, I really was very frustrated because my COVID duty was to help people die over the phone. I hate
Oh,
the phone,
oh God.
and it was very, very difficult.
I know.
And these were people in America, in France, in Bangladesh, in India, and I was really very frustrated. And then talk to the family, talk to the people as they die. And then I have nobody to talk to myself. So I just did whatever I had to do to keep myself going. I also went home visit. I wore my PPD and I went home visit on an auto rickshaw because dressings had to be done and people needed somebody to talk to. So that was my COVID time.
This is absolutely right, Hanife. I think this was this I really want to share that till now. First of all, I have not seen 405 deaths in 2 months, any time in my life. But till now, whenever patient used to die, people used to feel satisfied, and we used to prepare the patient and family member that he's or she is dying, and we used to be satisfied. But here we used to be frustrated that why this patient we couldn't do anything for this patient. So there was a frustration. So it was a unique and different experience that although we did everything, but this was a very I think still I feel that many of our patients, those young patients, those who have died, we could have done more, and they should have survived. So this was a feeling which really will remain always in our mind. Okay, Dr. Shabnam, you want to share your experience? Although time is over, but go ahead.
Good evening, ma'am. It was a
Yes.
very nice presentation, and your experience was really terrifying. Here also, we had so many patients, and I was not directly connected with the patients, but for 1 month, I was nodal officer. So I was looking after 106, 110 beds.
Mm-hmm.
And it was real chaos. Throughout the night, we used to get calls, ma'am, BiPAP is required, ma'am, oxygen is required. And we could provide oxygen to everybody, but still people died and very unexpectedly died.
Mm-hmm.
And that was really horrible. We were not so much satisfied. The same thing, you felt that for a moment you feel that patient is recovering. He is having good saturation. And then the happy hypoxia within 2 hours, they used to concoct. And rest all the same experience, but it was a very horrifying experience. In my house also, I was on COVID duties, my son was on COVID duties, my daughter was on COVID duties. So we were all having a COVID hotel, you can say, living in separate rooms and having separate dinner times. It was like that, but now it's relaxed.
Thank you, Dr. Shabnam. I know everybody. Dr. Nikat, what was happening in Army Hospital?
Good evening, ma'am. Ma'am, we also were overwhelmed, and although our own clientele is very disciplined and everyone wears a mask, and we've had a decent amount of vaccination across board, but at least in the 45 plus age group, we had the vaccination. But we were also tasked to look after the local civilians. So our setup is geared up for only that number of patients, the kind of clientele we have. So we had to open up wards and ICUs, and we were overwhelmed. But ma'am, in this time, I was the only intensivist here. So I was looking after the main ICU and guiding the others who were in the, by now everybody knows about treatment. So all the anesthetists were there, but I was looking after the the patients who were coming post-COVID negative, they were coming to ICU with lung fibrosis, pneumothoraces, all those people. Quite a few of them died. Quite a few of them had mucor. They were operated. But I would like to tell everybody, ma'am, I'd like to share one thing what Armed Forces was doing. That if you remember, ma'am, a lot of these temporary hospitals have come up all over the country. That is in Delhi, near the airport, Ahmedabad, Varanasi, Lucknow. Our teams had gone there, and we used to be talking to them every day, and they were totally stressed out because starting ICUs in tents and wards in tents, they are kind of tented structures, although they are excellent. I mean, a lot of facilities have been pumped into those, but they are still kind of resource constrained, and this time the mortality was very high. So we have this experience of working. Last year I was there in the Delhi hospital, Sardar Vallabhbhai Patel Hospital near the airport, and that hospital treated about 6,000 patients in the last wave. And this time, maybe I don't have the exact numbers, but this time the mortality was very, very high. And another thing was that your relatives and friends calling you because somebody turned positive, and another tendency amongst people who were not affected to call you and ask, where should I buy a concentrator? Sorry?
I think
So this
somebody has not muted their mic. Yeah, please go ahead.
Yeah. Yeah, so ma'am, a lot of people would call you, and I think other than the work, most stressful part was that at least 5 to 10 people you know very well were either getting affected or their close family members were getting affected, and they were calling you for advice. And I think, ma'am, in the things you wrote, that the things that created problem this time, one of them is WhatsApp, because people were getting all kinds of misinformation on WhatsApp, and they would call you कि हम ये करें, हम ये करें, and every time to convince them that this is not right, don't do this, don't do that. And we were on the phone so much, trying to guide people on the phone, trying to tell them the right things, and also telling people not to hold oxygen concentrators, oxygen and drugs. People were saying, should we buy it and keep it? And I told everybody, please don't, leave it in the market for those people who need it. Please don't collect these things that you might require them. Don't do it. So I mean, but even though I was not directly looking after the COVID patient in the acute phase, they came to us later on in the main ICU. But I think this was emotionally traumatizing for, I think, all of us. This wave, more than the first wave.
Trauma. It was a real trauma, Nikhat. Thank you. Dr. Cynthia, what is your as an outsider? There are a lot of people must be. Anybody wants to give any comment, please just raise your hands. Dr. Anupama, you have written a big paragraph. What you wanted to say? Please go ahead. Dr. Anupama?
Yeah, so ma'am, I never had any active COVID duty. Being the lone medical oncologist, I was spared of COVID duties. Although I had to, my residents and my nurses were taken away, half of them. So we worked with half the strength during the peak. Now, of course, things are getting back to normal. So I always felt kind of a guilt feeling that I have not actively contributed to taking care of COVID patients. But then I have my own responsibility of continuing with the onco treatment of patients, and I guess that's how it was. And
it was also very important to continue the treatment. There is no need to be guilty. That was also very important. So, Dr. Cynthia, give your final that what or how are you feeling after listening India's status, and then I will show you one very good photograph. Please stay back over here. One very important photograph I will show you. Please go ahead.
Thank you very much for that presentation. It was absolutely wonderful to see your leadership and to see, how you have managed these many problems. And I think that your advice about future steps is absolutely right. In the short and middle term, you vaccinate everybody. In the short term, you encourage social distancing and masks. In Singapore, we've been very lucky in that we have very few cases. I mean, we have 14 to 20 cases a day, and our total deaths is 35 at the moment. So it's really nothing compared to the problem that you're seeing. But we're very, very strict about vaccination. I think about 65% of the population have had at least one dose, and 40% of the population have had 2 doses. So, but that's a manageable population. I mean, in India, when you have 2.9% vaccinated, it's a very, very big problem, because we're now thinking about COVID not going away. We're talking about COVID being endemic, the way that flu is endemic. So the only way to manage it is to vaccinate so that the death rate goes down and the hospitals remain, not swamped in terms of ICU care, so that people who need the care are able to get it. But I'd also like to share some of the sort of international feelings about being affected by COVID. For example, some of you know that I've had family in Ireland. My son is he works in ICU in Dublin, and he looks after COVID patients. But nothing to do with him. My granddaughter, my 7-year-old granddaughter, caught COVID from one of the childminders. The whole family was in quarantine. So the little girl was COVID positive. She gave it to her mother, and she gave it to her grandmother, who was more worrying. She was 85 years old with lots of comorbidities. But fortunately, she was vaccinated. The mother wasn't vaccinated. Because she was under, I think she was 39 or something like that. So she couldn't. But the grandmother was vaccinated, and all of them have survived. This was in May. They've all recovered. My son's back at work. My daughter-in-law's back at work. But, really, this is a pandemic that affects everybody. And we really must look to the future. And I think the future really does look like vaccination, widespread vaccination. I mean, India's got the capacity to produce all these vaccines. But your rollout is very challenging, but it just is something that has to be worked on. And in the meantime, I think we have to do this public education about social distancing and masking and so on. In Singapore, how we manage is that everybody gets fined, and they can even be put in jail for not wearing a mask. And this is all implemented, so every day we've got newspapers saying, so and so has been charged. Foreigners who, unfortunately don't behave very well in our country, they have parties and so on. So we're not allowed to meet more than 5 people at one time, and they get their work passes cancelled. So all of them lose their jobs. So it's a very serious role that the government has to play in implementing these policies, which unfortunately is not possible in many countries. But thank you so much for your sharing, and thank you for everybody for your sharing, because, it's absolutely invaluable that, we've been able to share some of our humanity and the very encouraging things that we've heard, the sacrificial things that many healthcare workers have done for their country and for their patients. So, I think as healthcare workers, we need to pat ourselves on the back, including Hanife, who's been going out volunteering and helping all these people at home. I think we all have our own part to play. So thank you, Dr. Shushma, for your wonderful sharing.
This is my last slide, which I want to share, and I will ask everyone. Give me the let us start sharing my. I was sitting in my son's room, and he started having one more meeting. So, can you recognize this man? Who can recognize this man? Can you see the slide?
No, we cannot see your share.
Oh, sorry. Again, let me share the screen there. Okay. Now, who will recognize this person? Can you see now?
Yes, we can see it now.
Okay, so Indians, I am asking from India, that can you recognize this person? I will make this slideshow. With the one eye, so many bullet injuries. So this man's name is Chetan Cheetah. Do you know who is Chetan Cheetah? In 2017 encounter at Srinagar, this man got 9 bullet injuries, and he recovered from. Can you hear me? Are you listening? So this man recovered from 9 bullet injuries, and he remains for 6 months in AIIMS. And unfortunately, this man got COVID, and he was admitted at my institute on 9th of May with COVID. and he came with moderate to severe COVID, and today he got discharged. So this is the photograph that he got discharged. He was intubated twice. We intubated him twice. He remained on ventilator almost for 3 weeks, and we extubated, and he recovered well. So whole of the country, Miss like Health Minister of India, is also very happy that a hero, real hero, once upon a time, he saved us, and NCI Jajjar has saved this man again. So there was a big celebration in CRPF. He is a CRPF soldier, and we have sent him home today. So he is the one. He gifted one book to me that you should read that book, and I will read that book, Mratyunjay and something. But I just wanted to share the success story of this man. Where we have saved many lives, but this was a person who saved us once upon a time in 2017 in the border of Jammu and Kashmir and Pakistan border. Thank you very much. Thank you. We have overshooted time, which I never like, but today was a very important day. Everybody wanted. There are many people whose experience we have not shared. We couldn't share, but you can write your experience in the Lian Foundation group, and we will all read that how you have spent these 2 months and how you have done work like a warriors in the country. Thank you very much.